Hello, everyone. My name is Radwa. I did my presentation on aortic aneurysm. So, our agenda is we'll get introduced to our patient. We'll talk about the symptoms, their physical findings, their diagnosis and diagnostic tests, as well as their treatment plan. So, let's meet our patient. Our patient is a 67 years old male, TP. He comes to the hospital for a routine CT and ultrasonography screening. The triage nurse learns that the patient has been feeling not well after playing hockey with some friends approximately 2 days ago. He stated that lately he's been intermittently nauseous and has had one episode of vomiting. He has no allergies to any food or medications or any seasonal allergies. He has past medical history of hypertension, diabetes type 2, peripheral atherosclerotic vascular disease, COPD. He smokes about one pack a day. For family history, his father died at the age of 73 from AAA. He denies any past surgical history and doesn't really know what medications he is on. He is non-compliant with any of them. So for his physical examination, his initial vitals, his temp was 37.2 Celsius. His blood pressure is 115 over 87. Heart rate is 102. Respiratory rate is 20. And he is satting 98% on room air. On initial evaluation, the patient appears in no apparent distress, but is noted to be mildly unwell appearing and pale. His initial presentations is as follows. The patient denies any pain or discomfort and seems to be generally asymptomatic. Upon physical assessment, there is a slight diffuse abdominal tenderness when palpating his abdomen, but without any rebound or guarding. Additionally, there is a palpable pulsatile mass in the epigastrium area. The patient was sent to his routine CT. But after 20 minutes, the patient began to complain of acute onset of abdominal pain. He became lightheaded and has extreme nausea. His vitals were reassessed. His vitals now is blood pressure is 90 over 50, heart rate is 111, and respiratory rate is 23. The patient is now presented with the classic triad consistent of abdominal pain, hypotension, and pulsatile abdominal mass. The patient is then sent immediately to the radiology department for an ordered stat CT of the abdomen and pelvis without contrast to further explain the cause of his sudden symptoms. The repeat exam shows significantly worsened abdominal distension. Further test and reveal aneurysm with a diameter greater than 5.9 centimeters. Few minutes later, he is rushed back from radiology because um, he was found morbid appearing and minimally responsive. Um, so he was sent for an X-ray, which is the first picture on the left, shows the abdominal aortic distension. Um, that is a lateral view of his abdomen. And the X-ray does show the classic eggshell calcification of the AAA. This confirms the diagnosis with 100% specificity. The second picture, you can nearly see the 6 centimeter AAA that is visualized as that big black circle. On the third image, the arrow shows the apparent rupture. So although our patient was initially asymptomatic, he is now presenting with a new onset of abdominal pain in addition to the sign of classic triad. Therefore, he is presumed to have a symptomatic AAA and needs immediate vascular surgery consultation. with an urgent repair. His rapid decline in mentation and symptoms indicate a rupture of the aneurysm. So his diagnosis is based on the classic triad, on the imaging that we saw earlier, and his clinical representation and the progression of his signs and symptoms getting worse within minutes. For his diagnostic studies, his aneurysm can develop without causing any symptoms, or it can be present with spectrum. Physical examination is limited. There is a high percentage of missing or misdiagnosed in patients that is solely based on their physical assessment. Early detection is essential to prevent complications and even sudden deterioration leading to death. If left untreated or undetected, it can be fatal due to dissection of the aneurysm leading to instant death. For some cases of pre-hospital rupture aneurysm, the patient's operative mortality rate of treatment increases to 80%. However, for elective cases, and those are the cases that we catch the aneurysm early before they do rupture, the operative mortality rate is significantly reduced to 2 to 7%. At times, these aneurysms are discovered during a routine checkup and screening, such as our patient, he was asymptomatic and his aneurysm was detected on the imaging due to his symptoms. For high-risk individuals who are likely to develop an aortic aneurysm or have aneurysm symptoms, they are sent for routine imaging. In our patient's case, with his increase in age, the fact that he is Caucasian, with a family history of his father dying from AAA, his hypertension, PVD, the fact that he is a smoker, his hypertension, and his non-compliance with his medication did put him at a very high risk of developing the AAA, which he did. These patients are sent for imaging such as CT angiography, which is the gold standard as it is the most accurate test to determine the anterior to posterior length of the cross-sectional diameter and the presence of any thrombus in the aneurysm. Just the X-ray, which demonstrates the mediastinal silhouette of any abdominal widening. Additionally, an X-ray of the abdomen may also show classification within the walls of abdominal aorta aneurysm. Ultrasound is useful in screening aneurysm and to seriously monitor aneurysm size. The MRI can also be used to diagnose and assess the location and the severity of the aneurysm. Please note that although lab studies are not useful in the diagnosis of aortic aneurysm, CMP, CBC, coag parameters, and fibrogen type and cross-match are useful for the ongoing treatment if the patient were to further deteriorate and or become a medical emergency in the case that they do require blood transfusion. For treatments, aortic aneurysm can become a medical emergency, such as with this patient. Early detection is essential. A prompt treatment is imperative. Finding an aortic aneurysm before it ruptures offers the individual the best chance of survival and recovery. Any suspected AAA rupture warrants for immediate administration of high-flow oxygen. They will need 2 IV access, any of a large gauge of 18 or larger, if possible. Urgent blood specimen should be obtained with cross-match for a minimum of 6 units of PRBC, as well as other types of blood products. Any types of shock at this phase should be treated very carefully, as controlling the blood pressure, because raising the blood pressure will dislodge any clot and may precipitate further bleeding. Therefore, aim to keep the blood pressure, systolic blood pressure, 100 or less. This patient will need an immediate vascular consultation and will need to head to the OR for urgent repair. Complications of aortic aneurysm can be avoided if we identify the population that is at risk and have them do a yearly routine exam. Once an aneurysm has been suspected in an individual, multiple studies will then be performed to determine the exact size and location. The risk of rupture is directly related to the size of the aneurysm. The goal of management is to prevent it from rupturing. So a lot of times we'll do conservative therapy, which is used only in patients who do have small aneurysm sizes. It is consistent of risk factor modifications, such as decreasing one's blood pressure, putting them on beta blockers or calcium channel blockers that are commonly used, and to have a strict control of blood pressure. Monitor aneurysm every 6 months via CT scan or MRI, only if aneurysm size is less than 5.5 centimeters. Surgical intervention is indicated for individuals where persistent pain, coronary artery involvement, aortic valve involvement, symptomatic patients, or acute rupture. Surgical management includes clipping, wrapping, or coiling the aneurysm, or endovascular graft procedure. Clinical practice suggests that with aneurysm diameters, if the aneurysm is less than 4 centimeters, then the patient just needs to have an annual checkup. If the aneurysm size is more than 4 centimeters but less than 5 centimeters, they need to follow up every 6 months. But if it's more than 5 centimeters and the patient is symptomatic, or the aneurysm has became larger 1 centimeter per year, then the patient will require endovascular or surgical intervention. These are my references. Thank you so much for listening. I hope you enjoyed my presentation and learned a lot. Thank you so much.